Electrocardiogram, the ECG findings are just septal defect vary with the type of defect the individual has. Individuals with atrial septal defects may have a prolonged PR interval, first degree heart block. The prolongation of the PR interval is probably due to the enlargement of the atria common in ASDs and the increased distance due to the defect itself. Both of these can cause an increased distance of internodal conduction from the SA node to the AV node. In addition to the PR prolongation, individuals with the primum ASD have a left axis deviation of the QRS complex, while those with the secondum ASD have a right axis deviation of the QRS complex. Individuals with the sinus venous ASD exhibit a left axis deviation of the P wave, not the QRS complex. The common findings in the ECG is presence of incomplete right bundle branch block, or RBB, which is so characteristic that if it is absent, the diagnosis of ASD should be reconsidered. Here's the ECG of a 28-year-old male patient with ASD. In case you don't know what these alphabets are coded in the ECG, I can explain. So these are the first, second, and third electrodes attached to the patient chest. So AVR means augmented vector right, which is attached to the right side of the chest. AVL means augmented vector left, attached to the left side. And AVF, augmented vector foot, attached to the foot. And V1, V2, V3 are also coded for electrodes. They can attach up to 6 electrodes to the patient. And the explanation is here you can see the enlarged P wave indicating right atrial hypertrophy, and which even more the QRS waves are completely upside down because of the ASD. And also note that the AVF is predominantly upwards as compared to the lead one indicating right axis deviation. And RSR, which is the RS wave in the right side, the right electrode attached to the right side of chest, seen, and tall R wave indicating RBB, B, and RVH, which stands for right bundle branch block, or ventricular hypertrophy, again, right ventricular hypertrophy. And LAD with RSR wave in V1 is suggestive of osteum primum defect, which means LAD occurs in case that the electrical axis, wherein the electrical axis of ventricular contraction of the heart lies in frontal plane deviation between minus 30 degrees and minus 90 degrees. There are a few illustrations for electrodes attached the place of the attachment of the electrodes, like attaching to the right side of the chest, left side, and the mirror side, all the way down to the procostal places also. So explain that V1 and V2 are positioned in the fourth intercostal space. V3 and V2 and V4 are attached together, but the V3 lies halfway between V2 and V4. V4, V5, and V6 should be placed along a horizontal line. This line does not necessarily follow the intercostal space. And these are also the right atrium, left atrium, and lower the left leg lead should be just below the umbilicus. And that's all the exact illustration of places for electrodes. Here, actual footage of a same patient with ASD, but in this footage, the heart is upside down. These are ventricles, these are atriums. So this side is right atrium, this side is left atrium. So checking together again. Can you see this cavity here? This is PFO, which in this case, the blood from right atrium actually goes to the left atrium. You can see this again. Yep, that's what called ASD, or atrial septal defect. For treatments, patent for amenable. Most patients with the PFO are asymptomatic and do not require any specific treatment. However, those who develop a stroke require further workup to identify the etiology. In those where a comprehensive evaluation is performed and an obvious etiology is not identified, they are defined as having as cryptogenic stroke. The mechanism for stroke is such individuals is likely embolic due to paradoxical emboli, left atrial appendage clot on the interatrial septum or within the PFO tunnel. PFO closure. Until recently, patients with PFO and cryptogenic stroke were treated with antiplatelet therapy only. Previous studies did not identify a clear benefit of PFO closure over antiplatelet therapy in reducing recurrent ischemic stroke. However, based on new evidence and systematic review in the field, cutaneous PFO closure in addition to antiplatelet therapy is suggested for all who meet all the following criteria. Age 60 years at onset of first stroke, embolic appearing cryptogenic ischemic stroke, no evident source of stroke despite a comprehensive evaluation, and PFO with the right to left interatrial shunt detected by a bubble study. Echocardiogram. A variety of PFO closure devices may be implanted via catheter-based procedures. Medical therapy. Based on the most up-to-date evidence, PFO closure is more effective at reducing recurring ischemic stroke when compared to medical therapy. In most of these studies, antiplatelet and anticoagulation were combined in the medical therapy arm. Although there is limited data on the effectiveness of anticoagulation in reducing stroke in this population, it is hypothesized that based